Good afternoon, everyone. Michael Jr. speaking. I have some cases from the routine and then few older cases from our archive. I'll start with some recent ones. This is a case from a finger in a middle-aged female. You can see the acro type skin, which is the epidermis is normal, and in the dermis you can see this bland spindle cell tumor without mitosis, without myxoid stroma, some small vessels, nothing really too characteristic, but it's definitely benign spindle cell lesion. And in this location, always think in such setting about superficial acral fibromyxoma, because they have very broad morphological spectrum, and here it's immunohistochemistry quite helpful. These tumors are typically positive for CD34, which you can see here. And a very useful marker is retinoblastoma protein, which typically shows loss of expression in the tumor cells. Hope I can find it here. Okay. So we have nice internal control. The vessels are all positive, and the tumor cells show loss of expression. So with this, without the immunohistochemistry, with this morphology, I wouldn't be sure to call it that, but with this immunohistochemical support, I think this confirms the diagnosis: superficial acral fibromyxoma. Again, very broad morphological spectrum. You don't always need to have myxoid stroma, despite the name. So always think about it in this location. Next case was from the stomach. So it was an old, or not that old, 60-year-old lady who was known to have autoimmune gastritis. This is a sample from the corporal mucosa, which is pretty small, but in some areas you can see that it actually doesn't look that much like corporal mucosa, but the gastrin expression was negative here. There was some intestinal metaplasia in some areas, if I remember well. Yeah, here. And there were also some clinically polypoid lesions removed from the patients. I'll show you also antral mucosa first. So antrum is completely normal, at least to my eyes. And from the body of stomach, there were some polypoid lesions, and this is what we got. Any suggestions what that is and what the young ones? Peppo, do you know? Okay, so it's kind of damaged, but we see here proliferation which should not be in the stomach. These cells have yes, salt pepper chromatin or neuroendocrine appearance. They kind of still have this organoid arrangement, nested reticular a little bit. So this is a well differentiated tumor, and in chromogranin staining, this is chromogranin, everything is positive. So looks like we have a well differentiated neuroendocrine tumor arising in the background of autoimmune gastritis. As with any neuroendocrine tumor, we should do proliferation activity. So this is Ki67, which kind of looks pretty high, but I think many of these, or most of these cells which are positive, are actually pretty large. And the tumor cells, which are like half the size, are mostly negative. So I still think, I consulted this with Marian Schweiler, and we thought that this is less than 3%. So we still call it well differentiated neuroendocrine tumor, grade 1. The cutoff is 3% again. In general, these neuroendocrine tumors arising in the background of autoimmune gastritis are prognostically very favorable. They very rarely metastasize, and can be sometimes even treated somehow conservatively. Not sure how exactly, but from what I understood, the resection is not always necessary. There's another case. Was 50-year-old guy, soft tissue tumor adjacent to the rib under the scapula. This is the case you brought. And so what we saw here, let me go through quickly. There were somewhere were pieces of the rib, or I think that was part of the rib. Another slide. As you can see here, and then the rest of the tumor, or the tumor basically itself, was this lipomatous, well-differentiated neoplasm, and had these areas of kind of like bluish, somewhat cartilaginous looking areas, again with adipocytes in it, fibrous tissue. So I thought that there was a bunch of differential diagnoses. We are on the back, middle-aged man, so definitely spindle cell lipoma here was my first option. See this cartilaginous appearing stroma, but this I thought could be a metaplastic change. So I did CD34 and retinoblastoma protein. CD34 was completely negative in these stromal areas, which I don't say completely excludes spindle cell lipoma, but it would be very unlikely. Retinoblastoma protein was kind of hard to read, but I thought it was rather retained. Another possibility definitely is atypical lipomatous tumor, but MDM2 was negative, and there were really no atypia in the spindle cells. So with MDM2 negativity, this was enough for me to exclude that. And another possibility is just some variant of lipomas, sclerosing lipomas exist, and they are well described, and you can see metaplastic changes in lipomas too. And how can you support the diagnosis of lipoma? You can use HMGA2 immunohistochemistry if you have it, and most lipomas have HMGA2 fusions, typically with LPP fusion partner, and this is HMGA2, diffusely strongly positive in the nuclei. So for me, this was supportive of the diagnosis of lipoma with metaplastic, or sclerosing lipoma with metaplastic changes, which is how I signed it out. Okay, another case was a 23-year-old female, tumor on her wrist. And as always, start with low power, ideal scanning magnification. I don't show it here too much because it's hard to view, I think, on the microscope. But I always try to start on very low power scanning magnification, and here you will notice this area which looks like a lymph node, part of lymph node. We are on the wrist, which would be unusual site, I think, for lymph node, and especially although there is lymph node at the periphery, in the middle you have something else. So this proliferation of ovoid cells, which have kind of vesicular nuclei, mild atypia only, there was no major proliferative activity. Going back to low power, there were these like vascular or cystic spaces in the tumor, and these three features together, the lymph node cuff, or lymphoid cuff, it's not lymph node, lymphoid cuff, these cytological features and these aneurysmal cystic spaces together support diagnosis of angiomatoid fibrous histiocytoma. The terminology is confusing because we also have a so-called aneurysmal fibrous histiocytoma, which is a variant of common fibrous histiocytoma or dermatofibroma. But this one we see here, it's called angiomatous fibrous histiocytoma, and it has basically nothing to do with regular fibrous histiocytoma. It has different genetics. These tumors have EWSR1 fusions, typically with ATF1.
Was it positive? Positive?
Yeah.
For the spin?
I will get to the immunos. So there is no great marker for this, but you can use 3 markers to support it. None of them is always positive, but all 3 are positive in the majority of cases. So you can use desmin. In this case, there was indeed pretty good desmin positivity. There is never basically, or almost never, diffuse positivity. So basically, any patchy focal positivity is supportive.
They look dendritic, yeah, all of this.
Yeah, looks like there are some dendritic processes. Nobody really knows what it means, but this kind of expression is helpful. Then you can use EMA, which I don't have here. Similar, it's usually patchy positivity, not diffuse. And the third marker is ALK. ALK is often positive in these tumors, although there are no ALK rearrangements. ALK is also quite non-specific marker, definitely not specific only for ALK rearranged tumors. Okay, so next case, here this is an older case from our archive. I don't really know the location and age, doesn't matter that much. Typically these tumors occur in young patients. And we see something similar here, again lymphoid cuff at the periphery, it's somewhere in soft tissues. So again, it kind of looks like you have a lymph node and there is metastasis in it, but always think about this tumor whenever you see something like this in soft tissues. Lymphoid cuff doesn't equal remnants of lymph nodes. Here in the center, we have something that looks a little bit different here because it has myxoid stroma, but actually it's the same tumor. This is a myxoid variant of angiomatoid fibrous histiocytoma. It's one of the difficult things about soft tissue pathology, that basically any tumor can have a myxoid variant, and the myxoid stroma makes it look always a little bit different. But again, the cytological features are similar: ovoid or round cells with these vesicular nuclei with kind of like light or grayish chromatin. Looks a little bit empty. The chromatin looks kind of like empty in some cells, which I find quite helpful for these tumors. And very often you have some angiomatoid spaces or cystic spaces. In this case, not really found here. But these tumors are often quite bloody. So this is a myxoid variant of angiomatoid fibrous histiocytoma. Desmin was negative in this case, but I have EMA. This is control, and here we have EMA staining, again patchy focal, but it's there. This is the lymphoid infiltrate that doesn't count, but in the tumor cells, again some moderately strong positivity focal, but yeah, this is helpful. So myxoid variant of angiomatoid fibrous histiocytoma. Next case was a 41-year-old female, tumor on the lower leg. Small skin biopsy, normal epidermis, but there is something in the dermis and subcutis. So if we look more closely, you can see proliferation of these eosinophilic cells. They are often pretty large, epithelioid. Almost like rhabdoid. You may start thinking about some myogenic tumor. There are no cross striations really. It's just this kind of like a glassy cytoplasm, which is very deeply eosinophilic. Very helpful feature here is the diffusely, not very dense, but diffusely present neutrophilic infiltrate. And you can see how these epithelial cells dissect between the collagen. They go very deeply. So I suppose most people, including me when I saw this case, weren't sure what this is. So you can start with the basic panel for soft tissue tumors. So some, again, cytokeratins, EMA, S100, CD34, desmin. So in this case, we had cytokeratins here. So pretty diffuse positivity with cytokeratins. So is this carcinoma metastasis? Theoretically could be, but diffuse cytokeratin positivity in epithelioid neoplasm doesn't equal automatically carcinoma metastasis or carcinoma or epithelioid tumor. In this case, whenever you have in soft tissue tumors something which is cytokeratin positive, it's good to add vascular markers. So this is CD31. All tumor cells are positive with CD31. They were also positive with ERK, but I don't have the stain here anymore. It's in our collection somewhere. And there was one more marker positive, but that already says the diagnosis. So anybody would like to guess? This is so vascular epithelioid neoplasm with cytokeratins, epithelioid morphology, diffuse neutrophilic inflammation. So there was another marker which was diffusely positive in the nuclei was FOSB. So this is a so-called pseudomyogenic hemangioendothelioma. So the name, as you can hear, pseudomyogenic, tries to describe the myogenic-like appearance. So it can resemble some really rhabdomyosarcomas or myogenic tumors. Originally, this tumor was described as epithelioid sarcoma-like hemangioendothelioma because it also mimics epithelioid sarcoma because it's cytokeratin positive epithelioid. So that's a very important differential diagnosis. This tumor, in contrast to epithelioid sarcoma, always retains SMARCB1 immunohistochemistry. I don't know. Fly1 is quite worthless marker, I would say.
But it's positive.
Yeah, but it's positive in many tumors. Okay, next case is 43-year-old male with a tumor on the thigh, 4.5 centimeters in diameter. And we had this appearance. So quite cellular at low power. And another feature which might strike you are these numerous small vessels, which this arborizing appearance, a little bit similar as we know from myxoid liposarcoma, but there is no adipocytic differentiation, and in between you have these bland spindle cells, basically without mitotic activity. Also resembles a little bit solitary fibrous tumor, which is definitely a differential here. But STAT6 was negative, and typically all basic markers are negative in this tumor. So here, unless the morphology is typical, for confirmation you need molecular. So these tumors have AHRR fusion with NCOA2. This is soft tissue angiofibroma, described by Fletcher based on morphology. It's completely benign tumor, typically on the extremities, and basically the only clue is this combination of very prominent, innumerable vessels. In between the vessels you have these bland spindle cells. Everything is negative.
very large tumor.
Yeah, they can be large, and some 90% plus are on the extremities. They can be in the subcutaneous, they can be in the muscles. They're basically non-existent in the dermis, so very superficial cases don't exist, and they are very rare in like retroperitoneum pelvis. Only single cases described, and it's questionable whether those were true examples of this. So soft tissue angiofibroma, NCOA2 fusions. So next case was a 40-year-old girl with a tumor on her tongue. You can see again lesion covered by unremarkable squamous epithelium, and everything important happens in the surrounding structures. This tumor infiltrates the skeletal muscle of the tongue in between the mucinous glands, and again on low power what you notice is this myxoid stroma definitely, and the spindle quality of the or appearance of the cells. So long spindle cells with quite bland nuclei. Deposited in this very prominent myxoid stroma. Some areas don't have that much myxoid matrix. It's more cellular and hyalinized fibrous tissue. If you would do smooth muscle actin, the cells would be diffusely positive, typically at the cell membrane, so this so-called tram track pattern for myofibroblasts. And the diagnostic marker here, so a very young patient, myxoid spindle cell tumor with myofibroblastic appearance and staining with smooth muscle actin. And if you do this stain, anybody wants to guess what this is? This is ALK immunohistochemistry. There was also ALK rearrangement by Fish, and this was inflammatory myofibroblastic tumor. And so again, myofibroblastic appearance of the spindle cell, so long, plump spindle cells, bland nuclei, some inflammatory cells, and myxoid stroma, alternating with more dense and less myxoid areas. So IMT. So next case, this was adult male tumor in the abdominal cavity, and this looks on low power somewhat different there. This is necrotic tissue. You can see this tumor infiltrates into the intestinal wall. Some myxoid stroma again. And if we go on higher power, you can see again some spindle cells, but they are admixed with more epithelioid
What does this mean?
looking cells. Desmin would be positive here.
Okay.
And there are abundant again inflammatory cells. Here it's more prominent than in the previous case. The epithelial cells have this very prominent nucleoli. This is quite helpful feature. So this tumor is called epithelioid inflammatory myofibroblastic, but not tumor, but sarcoma. So it's a variant of IMT, or it's considered a variant of IMT, but it's always highly malignant. So it's called sarcoma. And because you have this epithelioid cells there, it's called epithelioid inflammatory myofibroblastic sarcoma. It's almost always in the abdominal cavity, typically in older males. Why it's thought to be a variant of IMT, basically it's because of this partially myofibroblastic appearance of the spindle cells, the inflammatory infiltrate, and also because these tumors are always ALK positive, typically at the cell membrane. They have this membranous expression, which is quite characteristic, and it's caused by one specific fusion partner of ALK, which is basically always present in these tumors. And again, extremely aggressive. In contrast to conventional IMTs, conventional inflammatory myofibroblastic tumors, as we saw in the previous case, are generally very low-grade indolent tumors, which may recur, but they very rarely metastasize, and even rarer is the cause. Does this tumor cause death of disease? So this was epithelial variant of inflammatory myofibroblastic tumor.
It's its own entity. Yeah, it's really. How many cases do we have? Few
Cases, single cases. It's very, very rare, luckily. And yeah, it's most likely a completely different entity.
One of the most high-grade sarcomas.
Yeah. Okay, next case. Don't again know the age and gender, but it's a sinonasal location for sure. You can see here sinonasal glands, which are unremarkable, and the important process is found in between them. No, this was CD34 negative, STAT6 negative. I don't have the immunos here. It's a case from collection, but just again bring the case again. For example, of this case again here. So this case definitely there looks like a quite cellular spindle cell neoplasm gland, no remarkable mitotic activity. So there is a very broad differential. Solitary fibrous tumor is definitely very important differential, but the most helpful features here is the immunophenotype. If you would do S100, it would be quite strongly positive here. And most tumors before in the old times were called either schwannoma, or when you have larger, more cellular variant of this tumor, they were called MPNST. Another marker positive would be smooth muscle actin, and often you can get a MyoD1. In the majority of cases, MyoD1 would be positive as well, or another skeletal muscle markers as PAX7 would be positive too. And this is so-called biphenotypic sinonasal sarcoma, which so far exclusively has been described only in the sinonasal tract. And biphenotypic is because it expresses neural markers, mainly S100 protein, and myogenic markers, mainly smooth muscle actin, and skeletal muscle markers such as MyoD1. Desmin is sometimes positive, sometimes negative. That's not that helpful, but MyoD1 is the best, one of the best markers for these tumors. And because the molecular background of these tumors contains fusions of PAX3, which is one of the myogenic genes, and there are now more and more cases described of high-grade transformation of this tumor, which can transform into basically high-grade rhabdomyosarcoma. I think these tumors are actually some skeletal muscle tumors, which just don't produce rhabdoid cells or rhabdomyoblasts very often. Sometimes you can see them, but not very commonly. So biphenotypic sinonasal sarcoma. Next case, this was a middle-aged male tumor on his upper back, and I think whoever has seen a few of these tumors can make the diagnosis from this look here, because these tumors always look basically the same, or 90% of cases look the same. So very well differentiated lipomatous tumors. And if you go around them, you will see just variably sized adipocytes, some histiocytes, some inflammatory cells, because there are these single cell fat necroses, such as here in the center with histiocytes around them. But there is no spindle cell stroma unless these tumors are, unless they recur and you can see the fibrotic reparative changes. There is basically never a spindle cell stroma, which is the main difference between spindle cell lipoma and between atypical lipomatous tumor. So no spindle cell stroma, well differentiated lipomatous tumor, or lipomatous neoplasm and this extreme variation of adipocyte size. And if you go on higher power, what is tricky and what typically leads general surgical pathologists to call these tumors atypical lipomatous tumor, are these, first of all, these lipoblasts, which are commonly present, and second of all, these hyperchromatic nuclei, as you see here. If I'm able to show it here, okay, so this is adipocyte with this hyperchromatic nucleus, which should never be present in normal benign lipoma, and it's always worrisome for atypical lipomatous tumor. So in this case, this is a case of dysplastic, or sometimes called anisometric lipoma. It's basically a variant of a benign lipomatous neoplasm,
Muscle necrosis, yes.
yeah, which may recur in some 10 to 15% of cases, so that it recurs more often than normal lipoma. But so far, no case has transformed into anything like dedifferentiated lipomatous neoplasm. So it's always benign, may recur, and don't mistake this for atypical lipomatous tumor, which has MDM2 amplifications. You can use FISH if you want to for MDM2 to differentiate it. So again, here one hyperchromatic nucleus. So this diffusely present mild atypia, no spindle cell stroma, huge variation in the size of the adipocytes, single cell necrosis with histiocytic rim around them. And these tumors are typically, or always, basically RB1 negatives. And several cases have been already described in patients with retinoblastoma syndrome. So there is an association with RB1 alterations. Sometimes they can be also multiple. So one of the last cases, this was a male, 40-year-old male, tumor on his foot. Okay, skin excision. Unremarkable epidermis. Again, everything important is in the dermis. And here we have something very cellular, very packed, composed of these atypical spindle cells, quite hyperchromatic nuclei. It creates these fascicles, intersect with each other. So you could start thinking about some spindle cell tumors, but here there is something on top of that. If you look closely in between the spindle cells, you can see a lot of blood, a lot of erythrocytes, which hopefully will make you start wondering whether this could not be some weird vascular tumor. And hopefully we'll do some vascular markers such as ERK, which is 100% positive. So this might be actually a vascular neoplasm. And another, okay, if you have a tumor that is positive for vascular markers and looks like this, so very cellular spindle cell neoplasm with fascicular architecture, I suggest the first thing you do next is HHV8 immunostaining, because this is a typical morphology for well-developed Kaposi sarcoma. And indeed, HHV8, which we see here, it looks basically identical to the ERK staining. This is HHV8, so human herpes virus 8 positive neoplasm, compatible together with the morphology, and ERK positivity with Kaposi sarcoma. So be attentive to this little bleeding in between the tumor cells. This is a sign of vascular neoplasm in this case. And last case, and the worst case, prognostically at least, was 27-year-old male, tumor in the paratestis. So you can see the testicular structures here, and There are a lot of these dark staining nested cells in this fibrous stroma. Anybody would like to have a guess? Young male?
Desmoplastic small round cell.
Yes. This is a textbook example of desmoplastic small round cell tumor. Again, very typical age and gender, young males. Most common location by far is abdominal cavity, somewhere on the peritoneum, but it can be elsewhere, including paratestis. It can also be in females, but it's much rarer. And this morphology, again, it's just a textbook example. These nests, variably sized and shaped nests of dark, mitotically active, highly atypical, small round cells. Sometimes you can have central necrosis in these nests, which I don't see much here, maybe in some other areas. And okay, here is an example. So this is, in some cases, this is very prominent, this central necrosis. And immunohistochemistry here is very useful. There is unusual combination of markers. So cytokeratins are usually positive. In this case, diffusely. Sometimes you have a dot-like perinuclear or paranuclear expression, such as here in the center. Sometimes you have this in the whole tumor, dot-like paranuclear expression. The same pattern of expression can be encountered with desmin. Here it's very diffuse and strong. Sometimes it's not so spectacular, but all cases should have some.
Dot-like.
Yes, it's paranuclear dot-like expression at least. But here in this case, it's very diffuse. A WT1 marker shows again either paranuclear dot-like or nuclear expression, and it's because these tumors have EWSR1 fusion with WT1 marker. WT1 comes from Wilms tumor. It's a shortcut of Wilms tumor because mutations of WT1, point mutations, are classical for Wilms tumors, but EWSR1 WT1 fusions are characteristic of desmoplastic small round cell tumor, and is one of the worst malignancies you can encounter in the human pathology. Basically, every patient dies. So desmoplastic small round cell tumor, typical example. So this is all from my side today. Thank you.
It was nice message. Massage of soft tissues. Michael, Senior. Just back to this soft tissue load. Even those that don't want to be soft tissue specialists should know as much as possible for soft tissues because they project to every organ. Yeah. And 40 years ago when I started doing pathology, I thought it was very difficult, but now it's horrible. Really, if I would be a young pathologist, I would keep every day an hour on soft tissues, even if I would not be specialized for it. Yeah. Okay, my first case is a 7-month-old child of tumor of parotid gland. You see that the tumor grows mostly in a solid way. Which is quite rare. Usually the lobulation is much more spectacular with some spinal stroma. Here the spinal stroma is very rare. And it's very rare tumor. They were described in the last 60 years, only 100 cases. And it's one of those celloblastomas. Yeah, I have written there. Celloblastom. No, dneska jsem to posílal, nebo včera. This tumor is usually, in most of the cases, FGFR2 mutated, which is a hallmark of it, but yeah, that's it, yeah. You see, it's very new paper that is in press, it still didn't appear. And these tumors having diffuse solid pattern or diffuse-like solid pattern are having mostly this mutation. Small minority of these are HER2 mutated as well, yeah. This type of celeblastoma very often recurs, yeah, and only very rarely metastasize. Yeah. Here it's written unfavorable prognosis, but among all other tumors, it's not as bad prognosis, but it often recurs. This, yeah, especially in contrast to classical celluloblastomas composed of small nests with glandular-like spaces. Here I have a lesion of peritoneal cavity, and it was a consultation from outside, and the clinicians thought that it's widespread metastatic carcinoma on serosal coverings. Yeah. When we did cytokeratin, I found some positivity, but not the typical one for metastatic lesions. You can take notice that this positivity is dendritic looking or spindle cell looking, and this positivity does not correspond to metastatic lesion. You see the dendritic quality of that, so that part of them would be subepithelial myofibroblasts because all of these lesions were cells were actin, smooth muscle actin positive, and smooth muscle actin is here. Yeah, you see all cells are smooth muscle actin positive. So my diagnosis was proliferation of subperitoneal fibroblasts or myofibroblasts, which are typically cytokeratin smooth muscle actin positive. But still, I am not persuaded that the patient doesn't have carcinomatosis of peritoneum. Just the clinicians didn't sample the right place, or the pathologist didn't send me the place where there would be positive metastatic carcinomas. The same cells that you see were stained A1, A3 cytokeratin, but the same cells were OSCAR, which is another widespread cytokeratin negative, which would be very strange for metastatic cancer. Yeah. So that I wrote, I do not see any metastatic cancer. I think it is reactive subperitoneal proliferation, which had to be caused something, I don't know by which. And please make more sampling, excise more things, and probably you will really find the cause of it, most probably metastatic cancer to peritoneal cavity.
It can be any injury, right?
What?
It can be any injury.
Any injury, whatever, yeah. You see these proliferations, especially in funiculus spermaticus, when there is a torsion of the testis. Yeah, when there is torsion, there is necrosis, and there is widespread, huge proliferation of spindle cells that are cytokeratin positive. Yeah, here I have amazing two cases. And one of them is this one, soft tissue lesion. I don't remember precisely. It was adult man. But because it's 30 years old case when we published in the past. And you see here these vascular-like spaces, which are sometimes have some hyperchromatic layering, but still you cannot say that these lipoma-like spaces are vascular or whatever, or lipomatous. Then you see these spindle-like. Můžu? Jo, tady. No. These star-like hyperchromatic cells, and very often these clearing around these cells opens and make these spaces, yeah. And all of a sudden, this soft tissue, without the transition, changes into these spindle cells. Yeah, it is typical second component. And this is hybrid dermatofibrosarcoma protuberans in giant cell fibroblastoma. We published the first case. Nahoře se to bylo
To jsme nahoře.
Ne, to není. To se ještě pokusili někdy. Jo, ne, to je jiný. Ale nech ho tam. We published in 1992, we published the first case of hybrid giant cell fibroblastoma and DFSP. And before that, it was described only in abstract form in 1982. That means for 10 years, there was no paper, and it was existing only in abstract form from one of the USCAPs where Ensinger and colleagues, Smukler, published it. And after this paper, I don't have the PDF here, there appeared many series of it, and now we have maybe 30 cases of these hybrid tumors. But soon after that, we published this second case, of which I have slides as well. This different case, again, I forgot, I don't have the clinical details, adult man, which looks very similarly. You see again these hyperchromatic cells is clearing around it, sometimes making even lipoma-like change. But in addition to that, you see here this spindle cell proliferation with many pigmented cells. And we published it in American Journal of Surgical Pathology. And this is the paper. It was the first ever published case where we had giant cell fibroblastoma, dermatofibrosarcoma protuberans, and pigmented cells, so that pigmented part actually was the Bednar tumor. It was final and the first just strong proof that DFSP or Bednar tumor is nothing else but DFSP with pigmented cells. At the time, Prague pathologists were very much against what we published here, and they considered it till the end of their lives, many of them, that Bednar tumor is storiform neurofibroma, not having anything to see with DFSP. Very few years after this paper of ours, there were published genetic findings describing typical translocation, the typical mutation that is seen in DFS, dermatofibrosarcoma protuberans. That means
PDGFRB.
PDGFRB, yeah. This tumor can be treated by by biological treatment by inhibitors. You have an amazing case that let us busy for a long time. It was tumor of mediastinum. A 50-year-old male. Was undifferentiated tumor. You see it here. Which was here is cytokeratin positive. It will be okay for the diagnosis, but the tumor was CD30 positive, so that you see at least some cells are clearly CD30 positive. What was strange was that was ALK1 positive as well, so that the diagnosis that was offered was large anaplastic lymphoma. Yeah, but we did further stainings. We did further stainings and we found that the tumor showed SMARCB2 deficiency. Some non-necrotic place. You see it mostly negative. SMARCA4 was nicely positive. You can see it here. But when we did genetics, we found that the tumor was SMARCA4 deleted, so that the pathologic finding was in this gene. But SMARCB2, I'm mispronouncing it, SMARCA2 was retained, and there was a big question how to explain it. Yeah, and in addition to all that, we found that the tumor had genetically E12 chromosome present. That means when it was a mediastinal tumor, this E12 chromosome amplification is seen in germ cell tumors. Yeah, so that there was widespread differential diagnosis. We sent it to Abbas Agaime, and he agreed with us that it is the typical undifferentiated thoracic SMARCB4 deficient tumor, and maybe the positivity in one gene and the negativity in another one is caused by epigenetic processes we cannot explain, and nobody can explain it because I'm not aware that anybody ever published that. And E12 isochromosome in such a high-grade tumor can be present. This tumor is very malignant, even when they try to treat it by biological treatment. Usually the biological treatment is functional for 2 or 3 months at most, and the patient dies quickly. This patient died just after we made the diagnosis, so that it only confirmed the diagnosis. You have skin tumor on the neck. And you can see that the tumor is nearly cystic. I'm sure that if the tumor opened through the epidermis, this debris would flow out and the tumor would be cystic. And it would be called then cystic keratoacanthoma with sebaceous differentiation. And these tumors are practically always typical of Muir-Torre syndrome. Here you see PMS2 immunostaining, which seems to be, this one seems to be positive, but here I have MLH1 staining, and MLH1 is negative with the exception of inflammatory cells. You see here that these cells are negative, only inflammatory cells are positive. So that this is definitely Muir-Torre syndrome in patients, and this patient should be treated by gastroenterologist to exclude polyposis or polypoid tumor of gastrointestinal of colon, and women should be seen even by gynecologists, because these patients are having very often endometrial adenocarcinomas. Okay, it's 3 minutes to the end, so that I will end up my talks. Let's see in a week time. Any question here? Thanks. Goodbye.